Hi, everybody. Welcome to this edition of the Asia Ventilation Forum, or the AVF ICU Tips and Tricks episode. Today, we are very honored to have Professor Margaret Herridge with us, who's going to talk to us about how she cares for survivors of ARDS. Welcome, Dr. Herridge.
Thanks very much, Jason.
Yeah, maybe I'll just introduce you. So Dr. Herridge is a professor of medicine, critical care and respiratory medicine at the University Health Network. She's the senior scientist at the Toronto General Research Institute, director of critical care research at the University of Toronto. She's also director of the Recover program for patient and family-centered follow-up care after critical illness. She's also clinical director of the GRACE Recover program for chronic critical illness for patients and families. And she's also co-lead of CANCOV, which is the Canadian COVID-19 prospective cohort study. So, Dr. Herridge, thank you very much again for spending time with us.
Pleasure.
So today we are going to talk to you about how you or we should be caring for survivors of ARDS. I mean, we all know that ARDS has got fairly high mortality, but we also know that after they survive the ICU stay, that's when often the long journey of recovery starts. So I wanted to ask you, what should we expect when the patient leaves the ICU for ARDS?
Yeah, thanks, Jason. Maybe I'll first start by saying that the ARDS literature, the ARDS outcomes literature really helped foster this whole movement of ICU outcomes that extend also to survivors of sepsis, of prolonged mechanical ventilation or chronic critical illness. So the themes in the outcomes literature after ARDS are very robust across many of these different groups. So maybe I could just frame my comments in that context. And the other is that really the ARDS outcomes literature grew directly from initial studies evaluating pulmonary function in survivors of ARDS. And that's really grown enormously in the last 20 years to evaluate multidimensional outcomes after ARDS and other survivors of critical illness. Really to 1 year and beyond, which really should represent, in my opinion, our new benchmark for long-term outcomes. The 30-day outcome, I think, in isolation, just isn't where we want to be anymore. And we really want to be focused on much longer term outcomes. So having said that, what are some of the things that are important to understand about longer term outcomes in ARDS? The first is that basically everyone, so this is a ubiquitous issue, has ICU acquired weakness. And ICU acquired weakness is related to both a muscle and a nerve injury that's sustained during the ICU. There are multiple risk factors, both modifiable and non-modifiable, and we can talk about that in a bit. But basically, this is a myosin depletion myopathy and an axonopathy that can occur either in isolation or more commonly together. And this results in enormous muscle wasting, weakness, where the weakness is more proximal than distal. The weakness is generalized. So patients will have challenges walking, they'll have challenges with activities of daily living, instrumental activities of daily living as well. They may have difficulties with swallowing because of the weakness of the pharyngeal muscles. So this is often a reason why people come back to the ICU. They have had episodes of aspiration or esophageal dysfunction. So ICU acquired weakness is important. And some of the people who've really helped put that on the map, Sandy Levine in his New England Journal paper showed diaphragmatic weakness as a major early morbidity occurring within hours of the onset of mechanical ventilation. And Zudin Puthacheri with Nick Hart, Hugh Montgomery, Stephen Herridge, and others in a JAMA paper described relentless loss of muscle in the first week of ICU. So there's a robust literature in addition to our own work at 1 year and 5 years, replicated by Elizabeth Foe and Dale Needham's group and others. In addition to ICU-acquired weakness, patients have neuropsychological dysfunction. So they have cognitive dysfunction, and Mona Hopkins was the person who first described this in 1999 in her Blue Journal paper, showing multiple domains of cognition affected. And this has been also replicated by many authors since. And the psychological dysfunction, the mood disorders are also very prevalent. So patients after ARDS or critical illness in general will have mood disorders and important issues related to anxiety, depressive symptoms, and PTSD. And recently there's an emerging literature highlighting suicidality and even suicide in the patients, but also the family caregivers. I'd be remiss if I didn't highlight the important brain ICU work. It's an important cohort led by the Vanderbilt group and Pradip Pandarapandi and Wasili, Jim Jackson, others who've contributed a lot to the neurocognitive outcomes literature, showing that patients after critical illness have cognitive dysfunction on the order of mild Alzheimer type dementia or moderate traumatic brain injury. So in addition to these things, though, which have been part of the so-called post-intensive care syndrome, championed by Dale Needham, and continuing to, and there's a sort of a continuing extension of that, because there are many multi-morbidities that these patients have, described by many groups, including our own, that extend beyond that initial PICS construct. So Nathan Brummel, in a recent paper in Critical Care Medicine, talked about the importance of frailty, which isn't technically part of the PICS definition. In our own Recover program, we've highlighted a lot of multimorbidities, pressure injuries, cosmetic injuries, contractures from prolonged bed rest and immobility, complications related to, for example, intra-abdominal sepsis with prolonged vac dressings, in situ, things that people don't necessarily think about. Craig Dale here in Toronto is doing a lot of work on oral health after critical care, and highlighting in some seminal papers that people have a lot of tooth loss, a lot of very bad gingival disease, need for root canals, injury to the mouth and the lips, and really helping us to understand again that there are multi-morbidities. So these are many of the issues that patients sustain. And then these have important implications in terms of being able to return home, being able to return to work and reintegrate into the community life that they led prior to their episode of ARDS or critical illness.
Right, thanks. So a whole host of issues you mentioned, from ICU-acquired weakness to cognitive issues, psychological issues, all kinds of multimorbidity, including teeth loss, can't return to work, etc. But it really struck me that you did not really mention pulmonary function, even though we were talking about ARDS, and I'm guessing there is a real reason for that.
Yeah, so thanks for highlighting that, Jason. Excuse me. I think there are a couple of reasons for this. In the early post-ARDS pulmonary function outcome studies that I alluded to initially, people really did not document important pulmonary morbidity. And also in our 5-year ARDS study, we did not see that either. And most groups have not historically. Now, that may be because when the ARDS patients are really severely ill, we are still seeing, mortality in the range of 40%. And it may be that what we're seeing is a survivorship bias so that the sickest patients are not surviving. So we're really following the survivors, and those survivors tend to have lungs that remodel. And that's why they survived, and tend not to have significant pulmonary morbidity. Now, I might contrast that, Jason, with the emerging literature, and we're doing our own Canadian multi-center study on COVID outcomes called CANCOV that you kindly mentioned at the beginning. The COVID outcomes literature, I think, is going to show something a little bit different. Now, in the one-year outcomes, the early one-year outcomes data, and the first paper that was published was led by Bin Cao's group from Wuhan. That was published in Lancet. And they showed some pulmonary dysfunction, but more modest. And they still had an important proportion of patients who did not fully regain their normal pulmonary function at 1 year, but it was a minority. And but they had a cohort who were critically ill, who were not predominantly on ECMO or really extremely ill. In our CANCOV study, and I think you'll start to see the ECMO data emerge, the sicker the patients are and the more we have rescued patients with ECMO, and this is just, sort of a general comment because the literature is emerging, but this is the signal in our cohort in CANCOV. I think what you're going to see is that some patients who traditionally would have died are being rescued and salvaged. And what is happening is that these patients often have more pulmonary dysfunction. And the pulmonary dysfunction in those patients is a combination of some fibrosis, a lot of bronchiectasis from recurrent ventilator-associated pneumonia episodes, so a lot of airway injury. And I would just say in our CANCOV study, we have many patients on home oxygen, in follow-up. And I have never had that in any of our post-ICU follow-up studies to date in the over 20 years that our group's been doing this sort of work. So I would just maybe make that comment that I think as we turn to advanced technologies and we're rescuing patients who historically may have died, I think what we're going to see is more morbidity, and in particular, maybe more pulmonary morbidity, because we're bridging people with significant technology that is allowing people to sort of just barely make it through and then be committed to some form of long-term oxygen therapy.
Right. So leads me to wonder, when we talk about the post-ICU syndrome and all these issues of ICU-acquired weakness, is it different, the component of the contributing factor of ARDS versus just critical illness itself, or actually are they one and the same? And a lead-on question to that is, long COVID. Is long COVID just another name for the same thing?
Well, great questions. The first, let me just address that. I personally think that there's such an enormous overlap between sepsis and ARDS. I think we're really looking at a Venn diagram with enormous overlap. In our initial, in our 5-year ARDS cohort, because I know that the best, the risk factor for ARDS was community-acquired pneumonia and sepsis. So how do you really delineate these? There's an enormous overlap in terms of, risk factors for ARDS, and what we know already from the sepsis literature, that sepsis also upregulates the ubiquitin proteasome pathway, just to speak in more of a basic science context here, that promotes the breakdown of myosin, that promotes this a breakdown. And we know that sepsis as well, or just sort of a systemic inflammatory response that we see in ARDS, promotes microvascular injury, which is one of the mechanisms that we invoke in the axonopathy of the critical illness polyneuropathy. So I think there is an enormous overlap, and whether you feel it's a full and complete overlap or only a partial overlap, people debate that, but there's clearly an enormous overlap. And we see the outcomes literature in ARDS basically recapitulated in the post-sepsis outcomes literature, and very similar themes in the prolonged mechanical ventilation or chronic critical illness literature, you know, championed by Shannon Carson, Chris Cox, you know, Judy Nelson, Terry Huff, others, you know, and so I think there's an enormous overlap. And personally, increasingly, I think it's important that we kind of come together and understand that these syndromic constructs have more in common than they have perhaps, you know, characteristics that are unique. Now, the second question is, you know, what about the post, you know, or the COVID, post-COVID or long COVID syndrome? So we've been looking at that in our group, as I mentioned, many groups internationally talking to each other about this. Personally, I really do feel that the post-COVID group are quite distinct. You definitely see that they have a lot of symptoms, but the symptoms that they have, you know, things like shortness of breath, weakness, muscle wasting, you know, these are very well described in the post-ICU outcomes literature and have been for a very long time, dating to, you know, when some of the, you know, we went from sort of pulmonary function to quality of life studies in ARDS, and those were, you know, early studies from the group in Seattle. Derek Angus contributed some of that early on. And then we moved to sort of multidimensional, much more granular outcomes data. But, you know, this is what you see in the post-COVID-19 literature as well. And I think that, you know, the weakness, as we've already discussed, the neuropsychological issues, if people spend a long time in the ICU, either on the vent or on ECLS, the constellation of things that we've already just talked about are very prevalent. And it gets harder and harder to really delineate. I think one important feature, though, is that COVID is really a multi-system disease by definition. So we know that, you know, the ARDS patients will have cortical, age-inappropriate cortical loss, apoptosis of, and that's related to apoptosis and neuronal dropout, you know, may have white matter changes, et cetera. But there isn't a primary injury. COVID, there's a primary injury because of the ACE2 receptor expression, and all over the body, including, you know, kidneys, everywhere, basically. So it's a very specific multi-system disease, and there are very specific multi-system injuries that may compound what we see in ARDS and sepsis and critical illness, but there are for sure a lot of commonalities as well.
Right, got it, thanks. Is there anything that we can do in the ICU to prevent some of these complications?
Yeah, and I think, you know, maybe I can break it down and talk about some of the outcomes and talk about how we can mitigate these. ICU-acquired weakness. Well, I think it's very important to recognize that tight glycemic control, and this was data published by Greet Vandenberg, tight glycemic control mitigates the axonopathy or the polyneuropathy of critical illness. It seems like a mundane thing to pay attention to, but it's very important. And also there's a signal, perhaps more in the pediatric than adult literature, that it mitigates the white matter injury and brain injury that we see in the post-ARDS or sepsis patient. ICU acquired weakness also can be mitigated through early mobility and ICU-based rehab. It's important, though, to highlight that the outcomes after critical illness with rehab are fundamentally influenced by the physical status and the resilience of the patient going into the episode of critical illness. And the studies that show the most impact of early mobility were in study samples where the patients were independent and really quite active and mobile prior to their episode of critical illness, sort of a signal for resilience. So we're still unpacking that a bit. And important also to understand that, and this is data from Samir Jabert in Montpellier in France, and Samir is a very senior critical care colleague of ours, early work that he did showing that the longer people stay in the ICU, they have a fixation of their sarcomeres, and their muscle may not completely recover contractile force. And these data were recapitulated by Claudia dos Santos in Toronto and Jane Bad, who showed that there is differential recovery of muscle bulk and contractile force after prolonged mechanical ventilation. This was as part of their MEND ICU program that they did in collaboration with our Recover program. So I think that's important. Rehab's important, early mobility is important. Diaphragm activation, and this is seminal work from Ewan Gallagher here in Toronto, also with Mike Sklar and Laurent Brochard and the physiology group here, showing it's very important to engage the diaphragm. We need to have patients on a spontaneous mode so that the diaphragm is activated, and that seems to be protective. And the diaphragm reserve, the thickness of the diaphragm also influences things. Now, turning to the brain, it's very important that we try as much as possible to not have patients in deep coma. This is some literature from Joanna Skrobic and others. Deep coma is associated with long-term neurocognitive dysfunction. Similarly, and this is data from the Brain ICU group and Pradek and Wes's paper in the New England Journal in 2013, that delirium and duration of delirium are sort of the most potent risk factors for long-term cognitive dysfunction. It's unclear still whether if we treat delirium that this is all going to be reversible, but important, very important association. And how do we mitigate delirium in the ICU in addition to using antipsychotics? We have family at the bedside. And in a beautiful paper from Brenda Poon from the group in Lancet Respiratory published during COVID, she showed so nicely that family at the bedside really mitigated delirium. And, this is one of the really regrettable consequences of not having family at the bedside during COVID. Neuropsychological dysfunction, anxiety, depressive symptoms, wakefulness, I've already said, is so important so that you can specifically treat symptoms in patients, pain, thirst, anxiety specifically, rather than just making someone more somnolent, not using physical restraints. Physical restraints are an extremely potent risk factor for subsequent development of PTSD. And these are important work initially published by Christina Jones and Richard Griffiths in London, and really put that on the map. And that's been borne out by others. Pressure injuries, again, our nurses are so exceptional in the ICU, working hard to, again, mobilize patients. We know this decreases pressure injuries. all the important interprofessional team members. I've already mentioned some of Craig Dale's work, but early work by Sue Burney, Linda Dennehy, more recent work by, Michelle Coe, Bronwyn Connolly, Carol Hodgson, important leaders, showing that just the rehab piece helps mitigate a lot of these things. Paying attention to dental hygiene, brushing teeth. These seem like very mundane issues, but gosh, they all add up. Even if someone's sick, passive range of motion, even if they can't participate in early mobility, even sitting in a chair, if they can't walk, all of these sorts of interventions. And there's a whole, ICU-based intervention literature. I've mentioned the physiotherapy scientists, and there is really the first important sort of RCT work from Lancet, and in the important Lancet paper that really put the whole ICU-based rehab intervention on the map, that was led by Bill Schweikert, and the senior author was J.P. Kress, and a close colleague with many of those doing important work in ICU-based rehab, and Jesse Hall in the Chicago group. There are many people. There are people who are doing, cognitive rehab interventions, and those are really, I would say, still being developed. Some early pilot work that's being championed by members of the Vanderbilt group, Jim Jackson being the leader of this work. But stay tuned on that. And I think it is important to remember that a lot of the muscle injury, nerve injury, brain injury, these multimorbidities have a durable impact. And I think this is what we were trying to show in our 5-year ARDS paper, and Elizabeth Foe really with the Hopkins group reinforced some of these principles that it's not that everything just naturally gets better over time. There really is an important lasting legacy for many of these morbidities for many patients. And, this is, a very key consideration. And I think now in COVID more than ever, because there are just so many post-COVID critically ill patients. So it's become an enormous public health issue. I mean, we've always known that the post-ARDS patients, or the post really sick critically ill patients, have long-term sequelae, and they use more healthcare resources, and they're costing issues. But we've never had such a volume of patients as now. And so it really globally has become a very, time sensitive issue for health policy planning and resource planning for these patients who will need ongoing rehabilitation, ongoing help with care transitions, ongoing mental health support, help return to work or job retraining, et cetera. And I think we're just going to be seeing these waves now as the 1-year data post-COVID is emerging from east to west, and people are really demonstrating that there really is a lot of healthcare need, that our current systems, regardless of what system you work within, are really not prepared necessarily to deal with.
Yes. So I'm reminded that often as intensivists, people who work in the ICU, we just focus on trying to save the patient, but we forget that the person that we save will leave the ICU and suffer tremendously. And a lot of what you mentioned, dental hygiene, removing the restraints are things that we often forget about, right? We just talk about upping the noradrenaline and increasing the band settings and the thing about families, we get them out of the ICU because of COVID, and we just forget about the harm that we potentially cause because of what we do.
100%, Jason. And maybe that's a good segue to just talk briefly about families and what happens with them, because I really think, and we did this in our Recover program and have really tried to, like very formally, but tried to do it in our prior ARDS and SARS programs. Like the family have their own parallel experience, and it's also extremely difficult, but it's often been invisible. The groups that really have helped to put family outcomes on the map, early work from Frederick Pochard and Elie Azoulay, Nancy Kentish-Barnes. They're really highlighting how the family is suffering, and the family is suffering not just with mental health issues, although they are profound. The families suffer from anxiety, depressive symptoms, very marked PTSD. But the unremitting, and I would just also say that those families whose loved ones have died in the ICU often go on to have very complicated grief reactions. And that becomes its own very important issue and clearly a priority to address at end of life. But the other issue that I think is less well known, and there's a JAMA paper published on this from a few years ago, that there was an increase in 4-year all-cause mortality in caregivers who were under a lot of stress with caregiving. And I think sometimes people forget that when caregivers are under enormous stress, that stress really does kill people. Unremitting stress really does physical, not just psychological harm. And these high levels of cortisol are really harming people. So the caregiver is really someone we need to, in my opinion, be looking after with the equal priority. And the one most important way I think that we can begin to look after the caregivers is having them at the bedside with us and enhancing communication, because we know from work from Elie Azoulay and Nancy Kentish-Barnes, and they published recent work in COVID, both in JAMA, that having the patients away from the bedside really exacerbated mood disorders. And Dr. Kentish-Barnes, in her JAMA paper, described in some qualitative data that the families described stolen moments with loved ones, that they'd been kept away at the end of life and they hadn't had a chance to have those moments of comfort, moments of closure, moments to be able to say what it is that you needed to say to someone before they left you. So so the patients suffer, they have mental health and physical issues. We need to have them close with us. They need to travel the journey of the ICU day to day with us, because then they'll very quickly understand that we're struggling. We're struggling in our decisions. Everything isn't clear to us. We're doing our best. We're being transparent and truthful and honest. That a lot of things are out of our hands. That a lot of the outcomes in severely ill patients are out of our hands. And people come to understand that it builds trust, and that's therapeutic. And I would say after the ICU, Jason, in follow-up, offering mental health resources. We've been doing that a lot through CANCOV, because we have the patients and the families following together. Offering other physical resource needs relating to illness that's probably been exacerbated by this unremitting stress of critical care, kind of heightened because of the isolation from their loved ones. So family caregivers, so important. And I think important, if I may also say, to be kind. The family caregivers are developing mental health issues during the ICU stay. They may be acting out. They may have challenges managing their stress, and to try to really have a lens of compassion for the families and non-judgment, not vilifying the families, the difficult family, the crazy family. We talk about people this way, and it's really, I think it's disgraceful personally. I mean, we're not here to judge. And I think it's really, I try to reframe this when I'm attending with the house staff and with the interprofessional team. Let's really try to cultivate compassion for people whose lives are really out of control. It's not clear what's going to happen. There's enormous uncertainty, and it's not everyone's built for this kind of stress or can cope or have a lot of natural supports, and it can get really, really difficult for them.
Right. Wow. Thanks, Dr. Herridge. You've given us a masterclass review of not just the physical issues that ARDS survivors face, but the psychological, the cognitive issues, and also what we can do for them in the ICU, after the ICU, as well as what the families face and how we should stop thinking of them as difficult families. Actually, yes, that's true, right? It strikes me that it's probably an international thing. There's difficult families in every ICU around the world, right? And it's a really good reminder for myself as well. So thank you for reminding us. For all of us.
For all of us.
For all of us.
Every day.
Every day. I don't know. I was going to ask if you have any last words for the audience, final words of advice.
I think the only thing maybe that I would close with, which is something I've been writing a lot about lately, is in addition to, and I'm not saying I'm perfect. I mean, I'm here as a colleague saying that I struggle with these things too myself, because we have a stressful job and a difficult job, and it is sometimes very hard to dig deep and find that empathy and non-judgment. I think what I would close by saying is that in addition to that, especially for me, seeing the COVID patients, they had so much isolation, They were isolated from the clinical team a lot. They were isolated from their families a lot. And it really heightened for me how crucial it is that we spend time in the room with the patients. And that we go in, we interact with them, even if it seems like they're in what we've done to them, a drug-induced coma, for all of the various reasons that maybe we feel it's necessary. But to go in, to interact, to touch people, because that's part of what a physical exam is actually having that physical connection with a patient, because you're their caregiver. You're not there to stand outside and look at the flow sheet. You're the leader, and you lead by example, and you go in and you interact with people. Even if you can't talk with them, because I've learned that a lot of the patients, there's a lot of tachyphylaxis with the drugs, and actually they're aware of more than we think, and they can hear us. To talk to them, to touch them, to examine them, to bring that clinical piece back into focus, and to interact with them. I've had such powerful sort of narratives from some families during COVID who said that they remember people in the room interacting with them, reassuring them, talking to them even when they thought they were asleep, feeling so desperately alone that they would die alone, totally alone, and commenting on some of the staff who came in. some of the nursing staff that they feel they owe their lives to because they were with them saying, "You won't die alone. I am here with you." And just reinforcing with me how important it is that critical care physicians remain fully doctors, that we're doing what we do when we're on the ward. We interact with people, we touch people, we examine people, and we look at all the data that all the technology produces, and talk to the families at length. But just to be very cognizant of that. And it was hard to put all the gear on and keep going into the rooms in COVID. Personally, I just had to force myself to do it. And also I was frightened initially too, like everyone else in the first few waves, right? I was really frightened about it. And like most of us, making my family sick. But so crucial that we remain fully physicians. And I think maybe that's what I'd like to leave everyone with. Then if people are in pain, if they've been tied down and they don't need to be. Like, you learn all of these things, but you will never learn them unless you spend time interacting directly with the patient and time directly interacting with the family. And I think maybe that's, key messages that I'd like to reinforce. And I struggle with them myself, but I try to force myself every day when I'm on service to set that example and to do that, because that's what the patients and the families tell me have been very important to them.
Well, thanks, Dr. Herridge, for the reminder. I'm a culprit myself. I just got to say this, right? Today I was rounding and there was a elderly lady with COVID in our ICU.
Oh, yeah.
And I was doing the usual thing, right? I was looking at the data outside and I looked through the window, the glass.
Yeah.
And I thought, she looks a little bit tachypnic. Maybe I should check on her. But my next impulse was, do I really need to? I have to gear up, wear the PPE, waste 5 minutes just to go in and come out.
I know.
The other patients to see, right? And
yeah,
I'm thankful that I went in, because when I went in finally, I realized that my impression was wrong. She wasn't tachypnic, but she was fearful. And she actually held my hand and she said, please look after me. And wow, that changed everything. It made me realize that, oh my goodness, what I could have missed, right? That there she was, fearful, alone, and she was looking for a healthcare worker to reassure her. And there I was outside looking at the charts and thinking, no, I don't want to go in. And I think it really made a difference for both herself and especially for me. So thank you for reminding me and for saying that.
Yeah, thanks for sharing that. And I think we all feel that way, right? We're under a lot of time pressure. All these patients to see, so much stuff to do, but we probably have that 5 minutes, right?
Yes.
And people remember that, and it helps so much. And you're right, it's both. It's us. We need to learn that, like it's feedback for us to help us be better doctors or better interprofessional team members, whatever your role is. And the patient will just remember it forever. Yeah, thanks for sharing that, Jason.
Thank you, Dr. Herridge. And with that very inspiring note, I think we'll end the podcast. And this was Professor Margaret Herridge, who was talking to us actually about caring for survivors of ARDS, but I'm sure you have noticed that we have gone a lot beyond that, also caring for family members of patients with ARDS, as well as patients who may not survive ARDS. With that, this was the Asia Ventilation Forum ICU Tips and Tricks series podcast. It's available on YouTube, on Spotify, and please feel free to share, subscribe, like, whatever. Till the next time, thank you again. Take care. Bye.